Good morning. I am given the task of talking on common fracture management. First of all, I must thank for inviting me for this lecture in Anuradhapura Clinical Society. So, yesterday we had a workshop in hospital, which was very successful. Sorry. And I must thank all the staff who helped in this shoulder workshop we conducted in the hospital. In fact, I am very surprised to see that some of the technologies available in the hospital are not even found in National Hospital Colombo. So we were able to successfully complete 3 shoulder arthroscopic surgeries in the hospital yesterday. So my topic is management of common fractures. It's very important to talk about disseminate the management facilities available in the hospital, because in this area where I work, we have found that most of the fracture managements are at the initial stages go to the native physicians. I start my presentation with this image, where at the initial periods of my service in this hospital, this is a 14-year-old boy who had a simple fracture of the forearm, and it was treated by native physicians, and it was all gangrenous. Very unfortunately, I had to amputate this child forearm. Therefore, I think we have to make a lot of effort to educate the public about the services in the hospital. Otherwise, it will end up in disasters like this. So in my presentation, I start with 3 important terms which are very useful for any doctor who is facing any exams in orthopedic. Commonly asked question is, how would you manage this fracture? If you talk about these 3 terms, then you are done. So you have to talk about how to reduce the fracture, how do you maintain it, and how to little bit of few words about how to do rehabilitation. So various terms like open reduction and internal fixation, closed reduction and external fixation kind of thing we can talk about if you know about these 3 things when you talk about any fracture management. So let's talk about first how to, after reduction, how to maintain reduction. So there are various ways of maintaining reduction: external fixation and internal fixation. And then we will first talk about how would you manage with fracture with external fixation. So external fixation is not by internal fixation, obviously, can be done with the casts. Plaster cast is a kind of external fixation. There are common types of external fixation. Plaster cast, above elbow, below elbow. Plaster used as various kinds of plaster casts can be applied for after reduction of fracture as a method of external maintaining of reduction. These are some of the images of the cast. I must tell that anybody who is on the plaster, we have to give some advices when they go home. Very important to know. And do not wet the cast. Sometimes get disintegrated. And do not walk on the cast. And do not rest the cast at limb on the heel. and that will damage the cast. Do not insert any objects inside the cast, and don't leave the limb hanging down, otherwise it will cause swelling and can cause a lot of pain because of the limited space for the swelling to occur because of the cast. And there are various ways of tractions. Nowadays, not much used. Basically, most of the fractures are being managed by internal fixation. Those days, when the facilities are not available, the fracture is maintained with traction. There are two kinds of traction, skin traction and skeletal traction. Skin traction can be applied almost up to 1/7 of the weight to 1/10 of the weight of the patient, and skeletal traction which higher weightage and has to be maintained with the for a couple of weeks to fracture heal. Nowadays, it's not being practiced very much. And there's a thing called external fixator, particularly useful in situations like compound fracture. For example, trap gun injuries in this area, because we cannot apply any kind of internal fixation, we have to manage this with external fixation. Very useful device. So external fixator, many uses. Sometimes you ask what are the uses of external fixator. External fixator is very commonly used in polytrauma situations when you have multiple fractures and then you don't have time to fix all the fracture and the patient's general condition is not so good. And then immediately you can apply external fixation for multiple bones and until the patient is stabilized. And also it's very useful device to in patients with infection after application of any native application with fracture coming with infection. Then of course you have to apply external fixator and wait until the wounds are healed and then go for the definitive fixation later. And also very useful method of deformity correction. External fixator is used to correct the deformities by dividing the bone and gradually correcting the angulations using the external fixator device. And lastly, the external fixator also can be used as a definitive fixation when the fracture is maintained for longer duration. For example, who had an infection, and then once the infection is healed, it takes about 3-4 months sometimes. Then when the fracture is healed, then we can leave it as it is. Then we come to internal fixation. When we talk about internal fixation, we have two kinds of devices, intramedullary devices and extramedullary devices. So we talk about extramedullary devices, that is, extramedullary means the device is applied outside the bone. And we have what is called dynamic compression plates and LCDB, low contact dynamic compression plate, and locking plates. I tell what these are. So this is called dynamic compression plate. So dynamic compression means some people think the fracture is mostly plated. These are not just plates like carpenters use, they have some function. You can see in this situation, one screw is fixed and then the other screw is applied in an eccentric manner on the opposite side. When the screw is driven inside, the two fragments compress to each other, making the two bones compress to each other. The advantage of having this is that when the fracture heals, it does not produce callus, which is very important in case of forearm fixation. When you have too many callus in two bones, it can get cross union between the two bones. Therefore, we use this dynamic compression plate for the fixation of forearm fractures as well as in articular fractures. We don't want to have a kind of callus formation. So this is the locking compression plate where you have screw threads have some in the screw head. So the screw is locked onto the plate. and making a very stable construct, for example, in very osteoporotic bones as well. Then you find various kinds of plates for various parts of the body, now which are called anatomical plates. So when we use plates, we are using in two concepts. One is functional reduction, that is for the absolute stability, and also an anatomical reduction. I think the terms are different. The functional reduction is relative stability, and anatomical reduction is absolute stability. So I'll explain what these are. So functional reduction is when the fracture is very comminuted, when you cannot have all the fragments put into one place, then you have a plate which are fixed proximally and distally, and then each fragment is not addressed separately, and what we are mainly concerned with the achieving of length, axis and rotation of the plate, and to let the fracture heals without touching the fractured area. That is called functional reduction. So I have shown some of the examples of functional reduction using plates. We can see the femur and the femur where you have different kinds of plates have been applied, but has never any fracture fixation around the fracture, any screws around the fractures. There's another tool for functional reduction, intramedullary nail. We use the nail to fix the fracture. The nail is passed through the medullary canal, and then main advantage of this is that it's a very rigid fixation. When the device is within the bone, it's highest stable than it is outside the bone. So we have various kinds of types of nails for the tibia, femur, and even small bones like metacarpal bones. We have different kinds of plates. So in contrast to functional reduction, we have what is called anatomical reduction. As I told you before, in the case of forearm, we need to have exact anatomy of the two bones to prevent callus formation. This is done by using interfragmentary compression. As I told you before, this picture shows you much better. And once one screw is fixed and the other screw is fixed eccentrically, when the screw head engages, the two fragments come together. That's why you call DCP, dynamic compression plate. These are not just plates, they are called dynamic compression plate, which are commonly available in any orthopedic theater. And also there is another thing called lag screw, where we fix a screw compressing two fragments together. We overdrill the proximal hole to prevent engagement of the screws on the proximal part of the bone. Then the screw head is tightened, the bones are coming together, compressing two bones. This is very useful in case of radius and ulna, where we don't want to have a fracture callus formation. As I told you before, if you have callus formation between two bones, there can be cross union. And we have various kinds of fractures in the forearm. One group is called Gallias fracture, where the distal radioulnar joint is commonly dislocated with the fracture of the radius. So, and in contrast, we have other variety where the ulnar fractures, which is called Monteggia fracture, and the radial edge is dislocated proximally. Therefore, it is very mandatory if you take any X-ray of the forearm fracture, you need to include both the distal and proximal joint to see these two varieties, which are actually we must fix with plates because these joints are already destroyed, and usually when the bones are plates anatomically, those joints heal naturally. So therefore, not to miss these injuries in case of forearm fractures, we must take X-ray including both proximal and distal joints. Now, little bit of talking about the articular fractures, very important. In contrast to long bone fractures, the articular fractures, there are principles of management of articular fractures where anatomical reduction has to be maintained because the joint architecture has to be reconstructed to the original status. There shouldn't be any step-offs and minimize incongruity. Alignment of axis has to be made. So, and apart from the anatomical reduction, there has to be stable fixation. That's the second principle. And there we actually employ this absolute stability, bone-to-bone compression by means of various devices and screws to prevent callus formation. And it allows early mobilization when you have stable fracture. So these are the three principles of articular fracture management: anatomical reduction, stable internal fixation, and early motion to prevent joint stiffness. So I take few examples of articular fractures. This is a tibial articular fracture, and then we need to have the same principles like before. We can see some intra-articular images of fracture fixation using various kinds of reduction forceps and making it an stable construct ultimately using kind of plate. This is a clinical example of reduction using some forceps and final images. And this is a distal femur. Similarly, we have an intra-articular fracture managed with a plate, bridging with the shaft proximally. When it comes to intra-articular fractures of the humerus, this is one clinical example of it's being restored to the normal anatomy. And we have various kinds of plates for different regions of the body, different parts of the body. Those are called anatomical fractures. Little bit of talk about collisus fracture, very commonly found in any OPD. There are various deformities. The reduction maneuver include the traction and disimpact the two fragments, and correction by palmar flexion and ulnar deviation, and finally stabilized in a cast for 6 weeks. You must know the certain parameters of the distal radius. When you reduce the fracture, there is a wall angulation of 11 degrees and 23 degrees of angulation of the radius styloid, and the radius is little too higher than the ulna. So we have to maintain these parameters when you do the reduction. And this is an external fixator applied in a situation like compound fractures. And in intra-articular fractures of the radius has to be fixed with open reduction and internal fixation to have absolute stability like I described before. When it comes to patellar fracture, usually patient encounter the pain, swelling, and tenderness of patella and inability to extend the knee because the extension mechanism is not intact. And usually clinical examination gives some diagnosis and X-ray confirms the diagnosis. This type of fracture we manage with what is called tension band wiring, which are applied to the patella, and immediately the patient can start weight bearing after fixation and start knee bending. If the fracture is, as it's an intra-articular fracture, we have to, according to the principles, it has to be reduced anatomically and stable. Talking about the femoral neck fractures, we have two kinds of fractures, the intra-articular fractures and extra-articular fractures. So intra-articular fractures, usually the fracture lines extend in the neck. The danger here is all the blood supply to the neck is coming from the neck, and when the fracture happens, it breaks the nerve blood supply, and the resulting in avascular necrosis of the femoral head. So we have different kinds of grades of external the femoral neck fractures, grade 1, 2, 3, according to displacement. If the patient is young, most of the time we try to fix the femoral head because some amount of blood supply is coming from the other side. But when the patient is older, this supply is reduced and solely depend on the supply from the neck, femoral side, and therefore very high risk of avascular necrosis of the femoral head. Therefore, we replace the femoral head, making it either hemiarthroplasty or total hip arthroplasty. So there are long-term outcome of fracture neck of femurs, about 15 to 30%, depending on the displacement of avascular necrosis happens, and non-union is due to poor blood supply. Secondary osteoarthritis is another complication due to fracture neck of femur, and mostly patients are functional impairment happens after fracture neck of femur. In contrast, the extracapsular fracture neck of femur will be managed with a surgical fixation like diadem hip screw or proximal femoral nail, because the blood supply is preserved there. Most of the time you can preserve the head. So in summary, the fracture neck of femurs, the extracapsular fractures are managed surgically with DHS, and the intracapsular fractures are managed with in an older patient with arthroplasty. Little bit of ankle fractures. There are 3 types, A, B, and C, depending on the location. And usually you can diagnose ankle fracture clinically by bone tenderness and at the posterior edge, and the inability to bear weight at least 4 steps. Then you can diagnose ankle fracture, then you send for X-ray. So there are certain parameters in the X-ray that you see to see the displacement in tibial overlap about 10 millimeters, and tibiofibular clear space about 6 millimeter, and medial clear space is less than 4 millimeter. You can find this in any book. And ankle fractures are if they're stable and managed with the plaster, can start weight bearing early. But in the unstable fracture, we have to fix with the kind of plate to fix the bimalleolar fracture has to be fixed with plates and screws. And syndesmotic screw is used when the syndesmosis is the joint between the fibula and the distal end of the tibia. If it is broken, there is another screw separately applied until the syndesmosis heal. Little bit of clavicle fracture, usually managed conservatively, and if it is shortened less than 2 centimeters and low demand patients, usually applied arm sling and kept for 3 weeks, and they can mobilize arm after 3 weeks. Most of the time, no need to fixation. But there are certain situations we need to fix the clavicle, particularly in cases of neurovascular compromise and polytrauma patients and pathological fractures, and certain failed management of conservative. But there is absolute indication for the clavicle ORF in rugby players, because we need to have the length preserved, because in their game they force shoulder to shoulder. We have to preserve the power. This is an image of a patient who has undergone clavicle fixation, but the challenge is to preserve all the supraclavicular nerve in the approach. If you get damage, they have permanent paresthesia in the anterior chest. Trap gun injury is a very common thing in this area. I have managed a lot of trap gun injuries while I was here. Almost 3-4 cases per week coming. External fixator is a salvage in this situation. I have collected some pictures during my stay. This is an image of a trap gun where you, most of the time, to trap animals, and people accidentally fall into this image, this injury, and unfortunately a lot of patients unfortunately end up in crippled life after trap gun. Really very disastrous situation I encountered in situation. Coming to the end of my presentation, I have to show you some images of this. This is one of the images I captured during my stay, where new JICA building is before the ground clearance, before the coming of the new JICA building in Anuradhapura Hospital. And I can show some, I could collect some pictures from my old albums. This is the opening of orthopedic ward in 2004 by me in the new building. Before that, we had our patients were in the surgical wards. This is image of Anuradha Circuit Bungalow where I stayed during my stay of 7 years. And of course, you can see a tree here, which is no longer there. This tree actually died when we were there, and we were very upset about. Immediately, we cut down the tree, and I planted a new tree. What you see today is the tree that I planted there 20 years before. Thank you for listening.